Okay, good afternoon, students. That we'll be talking on localization in central nervous system. As you know, the neuraxis consists of brain, brainstem, cerebellum, the spinal cord, the nerve root, the nerve, the neuromuscular junction, the muscle. So this is in broad the neuraxis, the brain, brainstem, cerebellum. Disorders um, will address slightly some of them. The next part we may be spinal cord myelopathy, nerve root radiculopathy, neuropathies which affect the nerve, neuromuscular junction problems, and muscle myopathy will take up in the next class. And the main important thing is that you should have a broad picture of the brain, which has got frontal lobe, temporal lobe, parietal lobe, and occipital lobe. That broad picture has to be kept in mind, and it has functions which are at various levels. So when you address a case of neurology in the outpatient department or inpatient, we follow a systematic way of examination which starts with higher mental functions and speech, the cranial nerves, the motor system, the sensory system, and the reflexes, cerebellar dysfunction features, extrapyramidal examination, meningeal irritation features, the spine and skull, palpation, peripheral nerves. We'll test gait and station, how they are doing. So this, in essence, is the whole CNS workup which is to be addressed, right? And so we'll learn some of these aspects in the bedside teaching, and here it will be a sensitization of what type of functions which are very, very important for us to learn. So you can see the important first function is the level of sensorium, how the individual is oriented to time, place, person, and what are his language functions, how the cranial nerves are working, the olfaction, the hearing, the vestibular function, the tongue, the examination, the muscular system, which has got the bulk, tone, strength assessment, along with the muscle stretch reflexes, are deep tendon jerks, where they are hyporeflexic, and where superficial reflexes are present. This is the examination which will teach you. The sensory examination, which will be superficial sensations, they are light touch, temperature, and that is pinprick, pain. These are the light. The joint position sense and vibration are called the deep sensations, and the graphesthesia, stereognosis, 2-point discrimination are called the cortical sensations. And you require a reflex hammer, you require a tuning fork, require a torch and an ophthalmoscope for that. You also, these are the tools which you do, and in the examination you also address the cerebellar dysfunction features, which are the finger, nose, and heel to shin incoordination. Also, you look at the dysarthria, dysarthria, nystagmus, dysdichokinesias in the upper limb, fast pointing, the tandem walk, the gait and station, that is stride length, turning, arm swing, the heel strike, the base, the Romberg sign. These are all you have to do, and to again emphasize that you require these tools for neurological assessment, the tin, the pins, needles, tuning fork, etc. we have to have at our disposal. Right. So with this brief note, we'll go on to the big picture of the brain. What is the big picture which is telling us? See, the cerebral cortex, the cerebral subcortex, the cerebellum, and this is the cervicomedullary junction which you have. So this is a big picture, and there is a left side of the brain, there is a right side of the brain. The left cerebral hemisphere is useful for two important functions. One is language, the other one is praxis. So these are the important functions of the left side of the brain. The right side of the brain, on the other hand, represents spatial representation. Right side of the brain, the spatial representation and the prosody are important on the right side. That means a geographical orientation, where an individual is going, and his music sense, and some of the apraxic ailment, they are all present on the right cerebral hemisphere. The dominant hemisphere controls the language and the praxis. Praxis we learn in here. So next, the brain has got two divisions also. No? The major central sulcus divides into anterior and posterior parts. Anteriorly, you have the frontal lobes, which are the keen. These are the much evolved structures in the central nervous system, and they are very much enlarged in human beings. And They are the centers of action. They are the centers of the action. Posteriorly, you have the parietal lobe, the occipital lobe, the temporal lobe. They are basically for perception. See, the perception is visual perception, auditory perception, somatosensory perception. All these perceptions, various senses, are their integration is done in the posterior parts, in the postcentral gyrus, calcarine sulcus of the occipital lobe, supramarginal gyrus of the temporal lobe. These are the parts which are the posteriorly placed, and this you keep in mind. And there are some things which are dorsal functions and ventral functions from the visual processing areas, and the connections of cortex, visual cortex, go in the upward direction. That will tell us the spatial orientation, where pathway, where a particular thing is there in the schema. And ventral is what is that? That is what is the face, what is this water bottle, what is the face mask, and this what pathway. By looking at it, we are able to identify that is the ventral stream. So this is a big picture of the brain. And then when we started learning neurology, we thought there are specific areas for specific functions. That is, frontal lobes have these functions, temporal lobes have these functions, occipital lobes have these functions, parietal lobes have these functions. They are true to some extent, but that only helps us in understanding the brain function. However, the brain is intricately connected with networks. These are the axons, the nerve cell bodies, the axons. One axon synapses with the next neuron at the dendritic process. How the neurons talk is the electric potentials or action potentials. So one part of the brain is closely connected to the other part, and these are called networks. Snapping of any of the networks will affect the information processing and ramifications over the brain function. So that's a microscopic anatomy of the brain. And you can see the perisylvian network, which is important in the language, which you can see here, the superior temporal gyrus, and also the frontal lobe, inferior frontal gyrus, and these are all connected with the axons. And this is the arcuate fasciculus which is connecting. This is the vernicase area. This is where you are getting the auditory input, and from there the vernicase area comprehension is affected. If this is damaged, comprehends things and sends the messages to the Broca's area to implement the task. So the action part is the anterior part. Similarly, you got a limbic network which has got the hippocampus region, and which you can see that, which will come back to it again, and which has connections to the mammillary body and thalamus, and mammillothalamic tract. From thalamus it is going to cingulate, and this function is a limbic network. It's very important for encoding the memory, retentive memory. This network of limbic origin is very important. We'll again see that. The parieto-frontal network, these are the connections from the parietal lobe to the cerebellum, to the spinal cord, to the muscles. These are all impulses traveling, the electric impulses, sodium potassium pumps in the cells, they create the action potentials and the brain, the parieto-frontal network. And the prefrontal network of attention and behavior is concentrated here. So this is the prefrontal network, which will again come back. That means all areas, especially this area, is called posterior heteromodal association cortex, because visual information is coming here and stored, auditory information is coming and stored, the somatosensory information is coming and stored. All this integration takes place here on the left side. This is the angular gyrus region, and this is connected to the frontal area. The frontal region, the perisylvian area, is the important network for attention. And the occipitotemporal face and object recognition, which I was telling you earlier, the straight cortex is the visual cortex, and The visual cortex is processing the memories that will store here to identify a face in the fusiform gyrus, and this is the dorsal pathway which tells you is the where is the item which you are looking in relation to the environment. That means this is a dorsal pathway and this is a ventral pathway. So this is a big picture. So after learning about the brain, its various left, right functions, ventral, dorsal functions, anterior and posterior functions, then we'll go on to these following things in a systematic way. That's how we examine the patients and whether there is arousal and awareness. The arousal or awareness, there are two things here. One is arousal means the individual will be stuporous but normal or comatose. So normal individual, how the awareness is maintained is because of the bottom up ascending reticular activating system which is connected from the brainstem midbrain to the cortex on both sides. These are the groups of neurons in brainstem. Just remember, whenever there is a neuron, it has got an axon. This axon is traveling up. That is bottom up ascending reticular activating system, which is spread to both the cerebral hemisphere, and this keeps us awake from the brainstem to the cortex. This is arousal. That means an individual can keep his eyes open and he can talk, he can establish two-way communication, he can perform and obey the commands, and also he can talk and understand. So this verbal, the eye opening, the motor function, all these are due to the functioning of the arousal systems. There is a top-down frontoparietal limbic and attention modulation. So the altered sensorium can be of two types. One is arousal disturbance. The second one is a content disturbance, where the individual appears to be in altered sensation in that sensorium, in that he will not be answering your questions, but he will be in his own world. He will be in old world means he will be in a state of flight of ideas, and that is the content disturbance. Because you are asking something to an individual, he is not replying, but he goes on talking something which is incoherent, irrelevant. That is the content disturbance. That becomes the awareness has been disturbed because of the disturbance in the frontoparietal limbic and yeah. We have to see that we are bombarded by sensory stimuli. Sorry for the disturbance because of the connection problems we are facing. So we are always bombarded by sensory stimuli that we filter based on salience. I'll show you an example of inattention blindness. See, the retina is capturing, you are asked to concentrate on the ball exchange between these two individuals. The retina is seeing everything all happening there, but its concentration is only on the one aspect, that is the ball. It totally disregards this chap who is walking across with gorilla suit, and that is not in his frame. The Brain is not paying attention to that, but brain is paying attention only to the ball. So this is what is inattention blindness, because you are focusing on one thing only. So that is what is the awareness and attention. This will be disturbed at the top down frontoparietal limbic attention modulation. This will be disturbed if there are lesions like this. The attention is tested by asking to say for digits forward and digits backward tests. The bottom up ascending reticular activating system, the reticular activating system which you can see in the brain, this can get disturbed, the reticular activating system disturbed, and may individual go into a state of unconsciousness, and which can be assessed by Glasgow coma scale. We say where the eye opening is present spontaneously, if not, whether he opens the eye on command, or if it doesn't open on command also, you ask them to apply some painful stimulus, and if there is no opening, then we break it as E1. So this is E is given E1 to E4. Then we ask him to obey the command, means show your tongue, lift your arm, not hold my hand. If this is able to do this task, then it is called M6. If he is not obeying, you apply some pain on the sternum. Then if he puts his hand there, that is called localization, that is M5. And if it is not, he is not localizing, but some movements are there in the body, then it is M4. And on extreme painful stimulus, if he is flexing the arms, extending the legs, we call decortication. If on extreme painful stimulation, if he extends both the arms and legs, then we call decerebration. And if he is no movement, that is M1. So you got E4, M6. That is an arousal disturbance assessment. Then third concept is verbal. Whether he is able to talk normally, whether his talk is incoherent, whether his talk is no, second is incomprehensible, third is incoherent, and it's groaning and moaning, no talk. So V5, V4, and V3, V1. So this is called GCS, and that is the score which we use for arousal tests. That brings, once the individual is around, let's look at the frontal lobes, which have got a dorsolateral aspect, the orbitofrontal aspect, and a medial aspect, and what are the dysfunctions. Usually an individual's organizational skills, his planning, and what he wants to do, and how to achieve a goal-oriented behavior, all these are in the dorsolateral region of the frontal lobe. And if there is a disturbance here, there is an infarct or a tumor, the individual become disorganized in his thought process. There is no planning, and he becomes he will be perseverating repeatedly, telling the same thing again and again, and he becomes stimulus bound. That means utilization behavior. If he sees a blanket, he'll cover himself with the blanket. So whatever is stimulus, he will react to that. And as I said, this is the region of the attention. There will be impaired digit span. The other mesial frontal region, that is the medial side of the brain, if it is affected, so what happens here? This is the place where individuals normal activity and how active he is, how forceful of his actions, and how actively he is functioning motor wise, speech wise, intelligence wise. If there is a disturbance in this region, the individual will become akinetic and mute. That is the importance of knowing an individual who presents to you with akinesia, is not moving at all and is not talking at all. That is the mesial frontal region. Now you see, the frontal lobes is what differentiates human beings from animals. The frontal lobes are much evolved structures in humans which will coordinate so many activities. The individual will be controlling himself, appropriate behavior as per the such social circumstances and what when to speak, and how to maintain his behavior in a appropriate manner is controlled by orbitofrontal region. If there is disinhibition, if there is a damage to this area, there will be disinhibition. The individual will become impulsive, emotionally labile, and vigil shut, and that is inappropriate jocularity and hypersexuality. So these are the important frontal lobe functions which we keep seeing in the OPDs, because the frontal lobes are the largest parts of the brain. So the dysfunction of the frontal lobes we frequently encounter in various disease processes, and we'll have to keep that in mind and learn to do attention tests usually, that is at least digit span test, to tell whether the individual's attention is there or not. That brings us to the aspect of memory. The memory is, as you see, there is a short-term memory, that is the visual stimulus and the auditory stimulus. These are called sensory memories, which have got a very small millisecond time frame. So the moment you see something, the moment you hear something, it's going into the brain. It's going into the brain through the optic nerve, optic tract, optic chiasma, and optic radiation to the calcarine cortex, in through the eighth cranial nerve into the temporal gyrus, and it is there. The primary sensory areas, and those areas will have to hold this memory for some time. That holding is called attention. Short term memory is into the minutes. Ability to hold the information across an undistracted delay, and it is concentrated in the prefrontal cortex. So memory can be immediate memory, working memory or the short term memory, recent term memory or long term memory, or remote memory, and procedural memory. So these are the types of memories which we come across, which we are going to test in the individuals whom we see. So the sensory memory, this we will not discuss much about that, but you people should know what is short term memory. The magical number 7 plus or minus 2, some limits on our capacity for processing the information. That means if you are asked to do a dialing of a telephone number, you can remember either 7 to 9 numbers or 5 to 9. That means 7 plus or minus 2 items only you can keep in the phonological loop of working memory, and you use that memory, you perform the task and forget about it. You are not encoding, you are not trying to retrieve it, so it won't get encoded. Then the working memory doesn't get encoded. So this is the long-term memory, that is the memory that is not lost by distraction. Here the memory is not lost by distraction. It requires the Papa circuit and hippocampus, where this short-term memory is encoded into the brain association cortex, that is called long-term memory or recent memory, which is a time frame of days and months, up to 6 months. The encoding goes takes place, and you can rehearse. So you require the hippocampus and the Papa circuit to encode this memory into the brain. The memories are stored in the large, vast association cortex. The association cortex is nothing but the cerebral cortex that is not having primary sensory areas. That means a large area of the brain is association cortex. All the neurons that are present, apart from the visual area, the auditory area, primary sensory area, olfactory area, these are all the neurons of association cortex, and the memories are stored in the association cortex. In fact, we will be surprised that only 10% of the brain function is so far being utilized by the humans. So they can store their memory, and they can consolidate their memory. That is the remote memory, the memory of events many months ago. That means the semantic knowledge is stored there, especially in the anterior temporal lobe and distributed in cortex. But this remote memory, to remember, you will not need hippocampus or the Papa circuit. That means in Alzheimer's dementia, you can remember your date of birth, you can remember where you grew up, what is your school, but you may not remember what happened last week, or what did you do yesterday, or what you have eaten for breakfast. That means recent memory impairment is the most characteristic feature of the Alzheimer's disease. That's how the importance of working memory. If attention is not proper, we cannot do any other tests. So digit symbol test is the most important test. Digits forwards, digit backwards, are the most important test to judge the prefrontal function. Then you do recent memory test and anterograde learning test for assessing the recent memory. For the remote memory, you have to have the recall. So that's remote memory is usually more than 6 months. So this is the hippocampus. You can see the entorhinal cortex, the phonics, and phonics is going into the mammillary bodies here. From mammillary bodies, you go to mammillothalamic tract, and from mammillothalamic tract, that is from the anterior nucleus of the thalamus, it goes to cingulate gyrus, and the cingulate gyrus to back to parahippocampal region, hippocampus. So this is the Papez circuit. This circuit is important to encoding the memories and to recall the memories up to 6 months till they are stabilized. This is very important. So the last memory is the procedural memory. For procedural memory, you need not have the hippocampus or Papez circuit. This is stored in the basal ganglia on cerebellum. So if an individual is asked to look at the mirror and a star has to be drawn like this, it's a very difficult task. He has to look into the mirror and draw on paper this. He doesn't know. You make him do this repeatedly. On first day there will be a lot of difficulty in performing these tasks. But by next day he'll perfect that without knowing what he's doing, but he will commit less mistakes by third day or fourth day. That means the procedural memory, which can be an individual can be trained, and he will perform that act without knowing why he is doing. That's the biggest advantage of Alzheimer's disease, that the procedural memory can be taken advantage to train them. So now in this memory segment, we learned about immediate memory, the short memory, the recent memory, the remote memory, and the procedural memory. In this only, we have something called a declarative memory and non-declarative. Declarative, the episodic memory, which is a part of the recent memory, is time locked. That means episodic memory means it is time locked. It has to be in reference to a time. What happened few days back? Where did you go last month? That is the episodic memory. The semantic memory is facts of the life. Who is the first president? What is the color of the jug? And what is the color of the pen? And these are the semantic memory. So you can see the various disorders that can affect the memory. This is the limbic encephalitis or episimplex encephalitis, which is affecting the mesial temporal lobe. This is the coronal section of the MRI showing the wastage or the atrophy of the mesial temporal lobe, and this you can see the vernicase or bodies are affected, which will affect the memory. So these are the some of the memory importance. The encephalitis, the vernicase encephalopathy, memory disturbances. So that being language, and the language section is yes. Now you can see the vernicase. This is angular gyrus. Now Right. So the large dominant hemisphere is involved. So the frequency of the speech is affected, the comprehension is affected, the repetition is also affected. These are the important aspects of the speech we test. And if you look at the Broca's aphasia, the spontaneous speech output is reduced, the fluency is reduced, but comprehension, visual, auditory comprehension, very well preserved. The repetition is impaired. The lesion is in inferior frontal gyrus. The transcortical motor aphasia, the, the only difference between this and Broca's aphasia is that repetition is preserved. Repetition is preserved. Sir, class. So this is the mesial frontal region, or the Broca's area is isolated from the surrounding area, where you get transcortical motor aphasia, fluency is reduced, comprehension is also preserved, but repetition is also preserved, unlike in Broca's. Look at the Wernicke's aphasia, where the fluency is not affected or increased itself. There is a logoria. He goes on talking incoherently or
Sir,
incomprehensibly. Yes,
sir, we
incomprehensible.
cannot see the screen.
You cannot see the screen. Oh, how
No,
come?
sir.
You. Oh, yeah. But since when you are not seeing? Oh, shall I?
There are
Yeah.
since types of aphasia.
Since aphasia. Okay. Let me see if I can. Uh, are you able to see now?
Yes, sir. Now it's visible.
Now it is visible? Okay, good.
Yes.
So transcortical motor aphasia we finished, and Wernicke's aphasia is the posterior superior temporal gyrus. Here the fluency is increased. There is no comprehension, there is no repetition. And its ally is transcortical sensory, where repetition is preserved. So that means repetition test is a very important test for us, which we have to do in all cases of speech disturbance, along with fluency, comprehension, and repetition. Transcortical mixed has got only repetition, there is no comprehension, there is no fluency. And the arcuate fasciculus, which is connecting the Wernicke's with the Broca's, if it's disrupted, you get conduction aphasia. So then sometimes you get alexia without agraphia when there is a problem of transmission of the information from one cerebral hemisphere to the other cerebral hemisphere. And like this, you can see that there is a disconnection of intact vision in the right hemisphere from the language area in the left hemisphere. So there is a lesion here, the corpus callosum. This information cannot reach this area. The language area cannot be distributed on the left side. So alexia, but without agraphia means he can write, because writing doesn't require reading, no. So alexia without agraphia, you have a disconnection syndrome when you got a left side parieto occipital region infarct along with corpus callosum. That brings us the most important and very interesting visual pathways and processing. You can see the visual pathways, which is the optic nerve that is coming, and the optic nerve, optic chiasma. This is the optic tract. This is the optic chiasma, optic tract. The optic radiations which are going into the cerebral cortex, the calcarine cortex, area 17 and 18. This is so whatever you are seeing, the visual field information is reaching the brain, the occipital lobe, and there are association areas which are around the primary sensory areas. Like we said, the primary sensory areas as visual area, auditory area, somatosensory area, where primarily the sensory impulses are reaching them as soon as the eyes or the ears, the skin sensations are stimulated. The various receptors will generate action potentials and they will reach these areas. And these areas are surrounded by association area which are called unimodal. They store these memories in them. Whenever the second impulse comes, they easily identify because they've already stored. not only the storage of primary sensory stimuli, they have to associate with others. Suppose you look at a boat and identify it as a boat. That means there is some association is taking place. You are seeing a visual area, and also you are trying to do to recover, or what is that? That question comes to your mind. So there is an association happening between the visual impulse and the memory which was stored inside you. You have to recollect that. You got to that thing is called association. The maximum association is in the dominant hemisphere, especially in the left cerebral hemisphere, especially in the angular gyrus and the parieto-occipital region. So the infarct in this region have got a very big effect on the mind. So this is the vision that is seen is, you can see that the eye, the left side eye, the cerebral cortex, occipital lobe, is catering to the right side visual field. And if you look at this, you see this is a macular area which is occupying up to 10 degrees in the pole. That means the macula, which is important for the vision, that foveation takes place in macula, it is represented on the contralateral side very much. The second one, you can see next 10 degrees, this much area only. And after that you can see this much area represented in cerebral cortex in a small area. And after that you have one monocular crescent which is present. Yeah, I'll just let me see what's the doubt you have. Which brain is getting stimulated when there is visual hallucination? That the visual hallucinations are temporal lobe, the right temporal lobe and the left temporal lobe. Left temporal is verbal mostly. Visual hallucination is the right temporal lobe, because visual memory is stored in the right temporal lobe. So that's it. The monocular crescent means this is the only area ipsilaterally represented. So whenever there is a problem in the eye, you can have visual field testing. The meridians are also given here. Upper vertical meridian, that means the yes. What's the chart? So the representation is like this. The upper meridian is represented lower, and the lower meridian is the upper, the horizontal is the depth. So the representations of the visual fields which are in front of our eyes, the right eye visual field is represented in the left calcarean cortex. The left eye field is represented in the right cerebral occipital lobe, calcarean cortex. So the if there is a problem in the inferior occipital infarction, you see the right side infarction is there. Here the visual field is as you see. So the left is left, the right is right. But in MRI, this is the ulta. The right is on your left and left is on right. So just there was some confusion. But if you see this field, which is occipital infarction in the inferior, you get the contralateral superior quadrantopia. This presents with visual blurring. So you have to do a confrontational eye test to identify this field defect. It can be done in ophthalmology department also, but bedside testing, whenever an individual says, I have visual blurring, you have to do the confrontation test to see whether he has got a field and field defect. Here is the temporal lobe tumor, which is on the left side, and it is causing the right supra quadrantopia. I said the visual field is in front of you. These are visual fields which are depicted here. This is the right visual field. This is the left visual field. But in MRI, it's reversed. That's why if you got a tumor here in the temporal lobe, then you get a quadrantopia. The right eye and left eye, these are the hemianopias, bitemporal hemianopia. This is called because of a meningioma which is in the suprasellar region. So the occipital stroke is showing a significant visual preservation. You see, the macular region is represented in the polar region of the occipital lobe. It has got a dual blood supply. Usually this region is hardly damaged in strokes. So what you get is a visual field defect with sparing of the macular vision. So this is a characteristic of the occipital lobe infarct. So this is the Alexia radiography. We have already seen this, so we're not going to go back to that. Now get the visual processing. So you see the dorsal where pathway is this, and the ventral what pathway is this, and this is mainly going to face area, fusiform face area. And if a lady complains of change in the appearance of faces because of this lesion here, she is not able to see properly. Why? So that is the connection. Now let us look at the visual attention. We are looking in front. We've got a right visual field or a left visual field. We have to shift our attention from one visual field to another visual field, on the same visual field also from one point to another point. This is called attention shift. So the right cerebral hemisphere is controlling the visual attention shifts in the left eye visual field, also in the right eye visual field. Whereas the left cerebral hemisphere controls visual attention shifts only in the right eye visual field. So that is the maximum difference. You see, the right cerebral hemisphere will control visual attention shifts in both the visual fields. This is the left visual field and the right visual field, and this is the left visual field. Whereas the left cerebral hemisphere will only control the left side. So you can see this is the normal eye, the right cerebral hemisphere, which is controlling the left also visual field and also right, whereas the left one will control only the left side. So what happens? Because of this problem, you will get a, if there is a problem in the right side, it is not able to see what is here. It can only say here because the left is helping. So what you get is a neglect, inattention on the left side. This is the reason. The reason is reason is because of the shifts in attention that are controlled by the brain differently. The right cerebral hemisphere controls the attention shifts in the left visual field, also in the right visual field. Whereas the left cerebral hemisphere controls visual attention shifts only in the right cerebral hemisphere. And if you are having a problem, then we call it as anosognosia in hemiplegia. Anosognosia means lack of knowledge about the disease. Anosogdiaphoria means lack of caring about the disease. In right MCS strokes, you usually come across this type of situation because of the mechanism I have described earlier. And this right parietal hematoma is hemorrhage is giving rise to a problem of the neglect. The neglect. If you ask him to cut these like this, and he is cutting only on the right side, he is not going on to the left side because left side is blocked for him, right? If you ask him to draw a clock, he will draw only on the right side because left is neglected. Ask him to draw a house and this part is totally neglected. So ask him to draw a flower, this is neglected. So this is what is called neglect, and that mechanism we keep getting in our ward. Right now in ward 6 there is a case who has got a neglect, and interested students can go and see that case. So anosognosia for hemiplegia, what happens when a patient with neglect tries to clap, and if he tries to clap, his left hand doesn't move at all. So but he doesn't know that it is not there, but still he goes on clapping, isn't it? Because he doesn't know that it is not working, he'll try and clap. So this has given rise to what is called East Chester clapping sign, a novel test of parietal neglect. How it happened? It's one of the 12th class students asked a teacher in New York, Madam, what happens if an individual wants to clap if he has got neglect? And the madam also didn't know. She rang up the neurologists out there. They also never thought about this. So they went up and examined all the cases. Then they found to their surprise that the individual started clapping only with one hand, not knowing that his left hand is not working. So that has been published in Annals of Neurology as East chest clapping sign, a novel test of parietal neglect. So one of the important things which we are going to now learn is the simultaneous or inability to perceive global elements. As I said, your visual field is right and left, and if you're looking in front, you should see everything and absorb what are all the things which you are seeing. You should not miss anything. But if there is a problem in the parietal lobe, especially in the bilateral parietal lobe, you will not be able to see the whole thing, but only you see a focused thing. You can see a tree for a forest. That means can't see the forest for the trees. Apart from that, you can have optic ataxia, that are poor reaching under visual guidance. You know that you ask him to touch, you touch his finger. First you touch your nose, then you touch his finger, and that finger you keep on changing directions in front. He will not be able to reach that finger because, under visual guidance, because there is visual inattention. That is called optic ataxia. Ocular apraxia means ask him to take a turn of the face from one side to the other side, from left to right. And if he is moving the head from left to the right, the eyes also have to move so that the foveation is maintained. But in cases of ocular apraxia, the eyes don't move. The eyes will move, especially a time lag of 3 seconds. That means the eyes keep deviating to the left side while the face is turning to the right side. This is ocular apraxia, poor visual search for subjects. And this is a Bellnet syndrome, which I was telling you. The cookie jar picture, there is a boy stealing the cookies. There's a girl standing next. The stool is falling. The lady is washing clothes, washing utensils. It is overflowing. What is overflowing? If I ask to describe this picture, the cookie thief picture of Boston Diagnostic Aphasia Examination, he will only see the part of this. The whole thing is not able to absorb. So this is the Bellnet syndrome, simultaneous nausea, right? That's what I did. Now we'll come to the praxis. So what is praxis? When the visual, the sensory system, the motor system, the coordination, everything is normal, yet he is not able to maintain the motor activity which he learned. The learned motor activities he is not able to maintain. And these are the coordinated programs. And you want to cut with scissors, you want to button up, you want to brush. You know that these are the things which are programmed and stored inside the brain. The movement, the idea to move usually happens in association cortex, and then impulses go to the basal ganglia. From there the programs get released, and the impulses then go to the cerebellum, where the trajectory, the speed, the rate at which the action is performed is decided, and then impulses go back to the precentral gyrus. From there the upper motor neuron takes the impulse to the lower motor neuron or anterior horn cells. Through that it goes to the neuromuscular junction of the muscle. The motor act is performed. So that is a very complex, super fast processing of information. Now all these things are coordinated motor programs which are stored in the brain, and that praxis is present in the left side parietal region. And what happens is, whenever this program, it is left side, and through the corpus callosum it goes to the right side also. So the supplementary motor area, right and left. So the action can be performed if all this circuit is intact. The program is performed. Apraxia results whenever there is a disconnection of these programs. That brings us to the motor system. The motor system, you can see the middle cerebral artery territory is this big, the anterior cerebral artery territory is this big. So the homunculus, you can see how much area the hand is occupying, the thumb is occupying, the leg is occupying, the face is occupying. There's hardly any area trunk. So most of the defects, and if this is the pre-central gyrus, the premotor cortex. So the MCA will have a flexion of the face, the arm, and the leg also. It's a large area. We can have affliction, but there is a difference here. The face and arm are much more severely affected than the leg. The face and arm are more involved in the weakness than the leg. If it is anterior cerebral artery, then it will be leg more than the arm. So an individual with stroke can have weakness. The weakness will be differential weakness if the lesion is in the cerebral cortex, because the blood supply to the brain is from the common carotid, internal carotid artery, which will give rise to ophthalmic artery, anterochoroidal artery, and it comes up and divides into antecerebral artery and middle cerebral artery. And that area, then each side you have a middle cerebral artery and an antecerebral artery, which are getting the blood. The blood flow is around about 55 ml for 100 grams per minute. It is getting oxygen and glucose constantly. If the oxygen and glucose are not reaching the brain, then there will be necrosis of the neurons. The stores of the oxygen, which is requirement is about 3.5 ml for 100 grams per minute, will last only for 2 seconds, and the requirement of glucose, which is about 5 milligrams per 100 grams per minute, will last only for 10 seconds. That means any blood supply blockage will lead to the cessation of electrical activity in the neurons and the necrose, and they cause weakness in the limbs. That is the mechanism of stroke. The MCA has got face plus arm weakness in the antecerebral artery leg, and if there is a border zone infarction, then there is a man in a barrel proximal arm weakness syndrome will develop. This is the motor system manifestations, and again there is a this along with this hemiplegia, there is always a facial nerve involvement. You got a facial nucleus, which I can show you in the next picture. Facial nucleus is supplying the facial nucleus, which is present in the pons, is supplying the fibers. These are the fascicular. This is the nucleus. The nucleus of the facial nerve. In the pons, it is supplying. The neurons are here. The axons are coming and supplying. So this nucleus is supplying only one side, but each nucleus is controlled by supranuclear fibers which are coming from the cortex. So the neuraxis has got a upper motor neuron and a lower motor neuron. The nucleus, the fascicle, the muscles. This is the lower motor neuron. So in presentation, we'll have to differentiate what is the supranuclear lesion and what is the Bell's palsy of the head. The bilateral representation is seen for the face. That means you see the supranuclear fibers are controlling both sides here, and that's why an UMN lesion, upper part of this face is preserved, it is not affected at all. Whereas if the lesion is in the nucleus or below, the whole of the face is affected. So the facial muscles are controlled by supranuclear fibers originating from the cortex, and they are descending down to control the nuclei which are present in the pons. And from the pons, the synapses takes place, the facial nerve nucleus and the fibers travel down. There is one more catch point here. See, central 7, the lower facial weakness only without the frontalis. There is no weakness in the frontalis muscle. But peripheral 7th, or the lower motor neuron, the whole face is involved. The frontal fibers are not there at all. So with frontalis weakness, that's how you differentiate. There is also one more characteristic. See, this is what I was telling you. This is the Abducens nucleus, which is coming. This is the facial nucleus and in the pons, and it is coming out. It enters to the internal auditory meatus and reaches the facial muscles. So the central 7th we have seen. This is the peripheral 7th we have seen. In the peripheral, this 7th nucleus is also controlled by putamen, globus pallidus, amygdala of the limbic areas. And see, from here the fibers are traveling down to home on to the 7th nerve nucleus. Here also there are fibers which are coming from cortex, which are homing on to the 7th nerve nucleus. So if there is a lesion here, what we read so far, central 7th and peripheral 9th holds good. But if these fibers are spared, what happens is there will be emotional smile present. To ask her to smile, she won't smile. if a situation develops where smile is elicited, she will smile like this. So that is the emotional facial palsy can be, if it's only these fibers are affected, you can have emotional facial palsy. So that brings us to the somatosensory system. The somatosensory postcentral gyrus also distributed like this. You can see the homunculus, how they are distributed in OPD. What we get is the sensory testing, which in this connection we have to do cortical sensations. The cortical sensory system involves three. One is 2 point discrimination, second is graphesthesia. You write some letter in the palm with his eyes closed. Ask him to identify what has been written. And you keep a thing in his palm without his knowledge. You ask him to close his eyes. You put a coin and ask him to identify that coin. That is a stereognosis. So all these three things, the graphesthesia, 2 point discrimination, and stereognosis, they are affected in cortical dysfunction. That means the crude sensations of touch, pain, temperature, proprioception, everything is normal. But this sensory information, which is connected from the thalamus to the parietal lobe, that is the third order neuron is taking them, it is not getting processed in the cortex because of the damage. So whenever you have a cortical sensory loss, these three modalities are affected and it reflects the cortical localization, right? So that's what is called is the this is a this is the stereognosis testing, and this is the graphesthesia testing. This is the 2 point discrimination testing. So these things, now we have broadly divided our functions into the left and right. The left hemisphere, a dominant sphere, and you got an aphasia, left gaze deviation, that is a gaze preference in, and the because right visual field defect, right hemiparesis, right hemisensory loss. So this is a left hemisphere lesion. The dominant hemisphere lesion, whenever there is a speech defect, there is right hemiparesis. So importantly, whenever right hemiparesis is there, you have to conduct aphasia testing. The important thing to note is typical aphasia syndromes which you have learned: Broca's, transcortical motor, the Wernicke's, transcortical sensory, the conduction aphasia, the global aphasia. These syndromes are typically seen after 1 or 2 months of the stroke. They are not there for you to localize immediately, but they will manifest slowly during the recovery state. This is the left hemisphere lesions which you have seen. The right hemisphere lesions now we'll see. Uh, the right gaze deviation, right vessel, the left hemi neglect, left visual field defect, left hemiparesis, left hemisensory loss. So the neglect is a feature of the right cerebral hemisphere dysfunction. You should understand this. So I think that's all from for this class. We have talked about the big picture, where the anterior is action oriented, the posterior is a perception oriented. There is a ventral walk pathway, there is a dorsal wear pathway from the calcarine cortex, right? These are the important issues which we discussed. And the right cerebral hemisphere, which is praxis, which is the perception and the visual or the geographic orientation. On the left cerebral hemisphere is language and praxis. That's what we said. We also discussed about the arousal and awareness. We discussed about reticular activating system, the difference between, we have discussed about the difference between the arousal and the content. Then we discussed frontal syndromes, the memory, the language, the vision, the spatial attention, especially to the right and left cerebral hemispheres, the praxis, the motor systems, this somatosensory processing. I think I'll stop here and ask any questions if there are, or any clarifications in the uh, portion that is so far covered. We'll cover the remaining part on Wednesday from 12 to 1. Any comments? Anybody wants to ask anything? Any questions? Any questions from anybody? Yeah, that's good. That's good. What is act of commission and act of omission? In what context you are saying this? You can talk. You can. What's the act of commission and act of omission? This is not in the brain function. I am not aware. In what context you are talking? Is it a motor function you are referring to, or so far I have not understood it in this fashion? In vigilance, okay. The vigilance is a different function which we didn't go to that higher functions here, and we usually we are neurologists, we don't go into that much into that function. So but one thing is known, all these things are in the frontal lobe. The vigilance, the organized behavior in the dorsolateral function. So maybe any defect will have. I have got no idea. Somebody else has to answer this. Yeah, some anybody, any faculty wants to say anything? Okay. So can you tell me, did the lecture help in any way of your understanding, or you got more confused?
Yes, sir.
Yeah. You got confused. You tell,
No, sir.
no, what do you want to say? Has any clarity come on any concept? Hello? Hello?
Yes, sir, we understood.
Shall we close? No questions? Shall I end the talk? Shall I close the session?
So there is one question left in the chat.
Oh, yeah. Is it? Okay. What deficit or damage of brain areas simultaneous amnesia observed? Bilateral parietal damage. Bilateral parietal damage. That I have showed you, no? The parietal damage will have simultaneous nausea and Bellnet syndrome, and
Yes,
it's
sir.
mostly because of the attention problems. Okay. Okay
Yes,
then.
sir.
Right. Thank you very much. Then we'll see you next week, next class. Bye.
Thank you, sir.
Thank you, sir.
Jai Hind.